Ryan Stanton here with ACEP Frontline at ACEP 17 in Washington, D.C., talking with Stefanie Simmons, who's got an interesting angle on things, and it's something I think we need to learn about. Is burnout, career engagement, wellness, and bettering the patient experience. And her specialty with her group is with physician engagement and coaching, something that we don't necessarily think about, but honestly, in medical school, there's a lot of things that are missing, and I think that's one of them, coaching on how we can do things better. We always get things and says, do this, don't do that, we're succeeding at this, we're failing at that, but there's rarely that ability and engagement to actually to address the individual physician, to say, these are your talents, this is what you're doing right, this is what you're doing wrong, this is what you can do better, and this is how we're going to do it. So talk to me, Stefanie, about one, where you're from, where you hail from, and how this became of interest to you.
Thanks, Ryan. I'm from Ann Arbor, Michigan. Go Blue, for those that are listening. And I actually am a lifer there. So I went to undergraduate, medical school, residency at the University of Michigan St. Joe's program, and then stayed with EPMG, which at that time was headquartered in Ann Arbor, Michigan. And we're now reorganized as the Midwest Operating Unit for Envision Physician Services. So that has been my general career path in education. And I developed an interest in patient experience and clinician wellness, and specifically the ties between the two of those. I saw an overwhelming approach to patient experience from the perspective of what do the doctors need to do differently or better than they're already doing, and not a lot of focus on how can we support the physicians and the physician assistants and nurse practitioners in the work they're doing so that they can do the best job possible. So it was a little bit of a twist or turn in that approach that led me down this career path.
I'm glad to hear that focus. I mean, I feel like I've spent my last number of years, especially at prior hospitals, getting flogged over the head on what I can do for patients, and every once in a while you sit down and think, what the hell is somebody not helping me with the situations that we have here with patient flow and support and physician health and wellness and things like that. So talk to me about the importance of what you do, which is the coaching aspect of things, in terms of kind of opening up that book of a physician or a provider and looking inside and seeing how they can do things differently, better, and longevity.
So there's two basic categories of clinicians that I coach, and the focus is very different because the population is very different. The first population are physicians or PAs who are in their first year or two out of training and starting in their first jobs in the sort of full clinical responsibilities. Residency prepares you very well to be an excellent resident, but it doesn't necessarily prepare you fully for that first attending role. So helping folks not step in the piles of troubles that are out there for them, and also to really engage in their full professionalism so that they can make a good impression with their staff, with the medical staff, and really develop a practice style that's good for them. So we do that by actually doing bedside observation of their patient flow and also their bedside style, and giving them directed feedback. And it's feedback that it's formative in that we do use a checklist of evidence-based behaviors that impact the patient experience, but we also ask our clinicians to reflect on their performance and build some intuition on whether things are going well with each patient encounter. So that's the first type of coaching that I do. The second is for folks that have been referred to me, either by the administration of their hospital, by their medical director, or occasionally by the nursing director, as struggling in some respect, whether that be a number of patient complaints or staff complaints, or whether the administration, the client, a hospital has asked us to remediate this physician. And unfortunately, sometimes that's not the ask. The ask is, can you get this guy or gal out of here? And at that point, we act as an umbrella, We're going to cover this doc. We're going to say, hey, listen, you need to give us a chance with this person to help them out and to figure out what's going on and to give them the resources they need to improve. And you need to give us some time to do that. So by having a process in place that we can get in and evaluate what's going on with that clinician, talk to them, mentor them, do some observation of what's happening in the department, and hook them in with some resources, that's helped us salvage some careers, and that's a benefit to everybody.
I think that's been one of the largest arguments that you see out there with the larger CMGs, is the contract management groups, is that the physician does kind of lose some of those rights and that due process. I've worked at a hospital in the past that during the 5 years was 5 doctors told off the schedule. And I understand contracts, and I understand the hospital administrative easy button that they're trying to hit. But to me being in the trenches there with them, it was a life, it was a person, and I think that's a huge drive now with physicians is pulling back some of that control, and how do we become the decision makers in our facilities, but also how do we make sure that we have due process, that we're given the rights that we would expect in any job, but especially a job where we have an entire family involved in a facility and want to be able to work where we want to work, and not worry that any given moment, the next month, I'm going to be off that schedule. And I've just seen it way too many times. And so I was happy to hear you mention the umbrella of protecting the physicians and working with them, because I think one of the great weaknesses is that worry about the contract, that it makes it easy to say we want to protect the contract, and so we're happy to kowtow to your administrative demands of saying this physician needs to be off the schedule. And I, from my standpoint now, being fortunate enough to be in a small Democratic group, but I never know how things are going to happen down the road and how things are going to change. But pulling back around here, getting off my little soapbox of physician rights and that sort of thing, where do you see? I'm sure you've had exposure to hundreds of, if not more, providers, physicians, NPs, PAs. Where do you see some of the faults, the breakdowns coming? I mean, I think one of the big challenges for physicians, at least, is that, we're sitting here, I'm kicking your foot with my big old boots in here. And then medical schools, the really having a good delivery personality is not necessarily part of that entrance qualifications. Whether it's the MCAT, whether it's your interviews, whether it's your CV with your qualifications, I think it's something that's significantly missing, that we're expecting our physicians when they come out of med school and residency to be professionals at interactions and dealing with people and during very sensitive times, and yet it clearly is something that's not taught enough and that we have to learn as we go. So what are some of the big mistakes, some things that you see happen consistently that the physicians are making that we can easily, or at least attempt to wipe out?
Thanks, and don't worry about kicking me. I'm pretty tough. Well, you're exactly right. It starts at the selection process for medical school and the types of students with the type of diversity of backgrounds and behaviors and experiences that we're selecting, and some schools are doing a really good job of changing that. It goes through medical school and residency training, though, and we really develop a pathological set of coping skills during that experience that we need to get through some of those experiences of that intensive learning and intensive training environment. The problem is when we can't put those coping mechanisms away in our personal lives, they destroy us. And we really spend these 4 years of medical school, 4 or 5 years, 3 to 5 years of residency in training those coping mechanisms deeper and deeper and deeper, and then they don't serve us for the rest of our careers. So to a certain extent, it's retraining how people think about things. Things like, it's okay to ask for help, or I don't have to do everything myself, right? So the few areas that people end up getting into the most trouble with are teamwork with their nursing teams, and really being the leader of the team, not just the leader of the clinical care, but the leader of the flow and the leader of the attitude of the shift, right? So if you come in and you're a gloomy Gus in an ER for the shift, everybody's going to take that cue and your shift's not going to go as well. If you're complaining about patients, if you're lacking professionalism in how you're describing them or talking about them, the nurses take the cue from that as well, and that leaks back to the patient in addition. I coach a lot around opioid communication. I think this is a perennial frustration for all of us, and I do work in the ER as a physician as well. But when you're having that patient that you feel like is manipulating you or as a secondary gain, or even just is asking for opioids and doesn't understand why you don't want to give that medication to them, it's a frustrating experience for folks, and especially people who have addiction in their family of origin or have strong social, religious, or political beliefs around opioid use. They sometimes need a little bit of retraining and a little bit of practice, role-playing through those discussions to get to a point where they're not standing in front of their patient with their arms crossed, like Gandalf, you shall not pass, but rather they're standing beside that patient and pointing it in a different direction, in a safer direction for them. So that's a big area that I often coach on. Another area is, just making nice. How do you go into a site, particularly if you travel or you're in a site where you haven't worked before? How do you go in and make that first impression with the staff? Not just the nursing staff, but the clerks, and the techs and the admitting doctors, and let them know that you are a professional emergency physician who's there to care for their patient and to care for the patient in front of you, and that you're going to do an amazing job, and that that's your goal. And so I think particularly in departments that have a checkered past with regards to the quality and interaction of the staff, it's so important to be able to lead that interaction. So coaching people through how you make that impression and how you present yourself, it has been critically important.
I think one of the big areas of fault that I continually see is communication. Physicians aren't always great at communication, especially emergency physicians, because we're in a hurry. We've got a lot of things going on, but the patient doesn't understand the context of 20 other patients in the department or whatever's going on or what you've seen or what you just came out of or what's coming up next. That communication. And I think us in emergency medicine, a lot of the care we see is because of poor communication from the outside, not giving the proper information. I mean, really, if you think about emergency medicine in general, there's a lot of things that are going to sort themselves out. We can help with symptoms. We can help with diagnostics. But really what people are mainly looking for is information, in most cases. Information and education. Understanding that in pediatrics, a fever isn't going in itself isn't going to cause brain damage. Understanding that your chest pain evaluation can rule out an MI, but does not necessarily mean the pain is not cardiac. That takes a lot of time, and I see a lot of conversations about us having conversations and communications with our patients and being able to sit down and have those talks. And I'm sure you see that on your end of the spectrum. So talk a little bit more with us about those communications and those things that you can do as a physician at that bedside that helps foster understanding, education, compliance, and in the end, satisfaction.
It's great because in the question, you actually mentioned the number one thing, which is to sit down and have that conversation. The operative word here being sit. And, I used to sort of squat sometime at the side of the bed when I couldn't find a chair. And now as my knees get older, I'm pulling that chair up more and more. But getting actually physically down at the patient's level. Patients want three things in addition to the correct diagnosis and treatment. They want to feel cared for. They want you to listen to them, and they want you to explain things in a way they can understand. So there's behaviors that track to each one of those goals, right? They want to know they're cared for and respected. Well, if somebody visits your home, do you know the name of everyone who comes with them? Yes. If you're in a room and you don't know everyone who's in that room and their relationship to the patient, that's a problem. It shows a lack of respect for those people who are important to the patient and are there with them. Do we show dignity for our patients? Do we offer them a covering for their bodies when they're in the emergency department? Do we offer them water if they're thirsty and able to drink? They want us to listen, And so that means actually listening, which means closing our mouths and opening our ears and letting the patient talk. Most patients will get the kernel of their story out in 45 seconds, and then we can ask our provocative and palliative questions. 45 seconds is a long time for any doc to listen, but I think particularly in our fast-paced environment, it can be hard to listen for that long. It saves time later on if you can do that, because they'll often tell you that critical piece of information that you won't get if you're not listening at that point. And then they want you to explain things in a way that they can understand. So Ryan, I had a guy the other day who's a 59-year-old man who came in with a STEMI in the anterior leads, went to the cath lab with some Berlinta, ended up getting 2 DESs in the proximal and distal LAD. His EF took a hit down to 15%, and he's in the CCU. How much of that was English?
Not much.
Very, very little. But that's the way we talk to each other, and it's really, really easy to slip into that technical medical jargon when we're talking to our patients. How often do we say somebody's getting a CAT scan, an MRI, or an echo, and we don't explain even to them what that means? Because that's our bread and butter in our daily life. So we need to make an extra effort to be approachable to our patients, to explain things in a way they understand, and to really listen to why they're there. Every patient I've seen in the emergency department who's constipated is worried about the same thing. You know what it is?
Most of them just want to have a dump.
Okay, granted, and that is definitely the relief that binds. But, I think many people actually are worried that they have colon cancer. Otherwise, they wouldn't be in the ER, right? They'd be taking a laxative from their grocery store. If you don't know that that's what they're worried about, you're never going to address that with them. And after they've taken that dump, you're not going to refer them to get that colonoscopy if that's indicated, right? Or encourage them to do that. So asking, what is the thing you're most worried about, right? And just getting to that level of the conversation with them can be critically important.
You actually hit on what I was going to mention next, which is that getting to the chief fear. Because we can rule out things that we think are important, but why is that patient here? You mentioned the constipation with the colon cancer. I do have a lot of patients who really just want to pass that little baby-sized poop ball that they got sitting in there, and that's all they want. And but really getting down to the bottom, what is your fear? And what I find many times, it's a family member that has recently had an issue, or somebody they know that has passed away or had a complication. So your 24-year-old that shows up with chest pain and it's not a big deal. It's probably pleurisy, costochondritis, maybe it's an indigestion, chest wall, whatever it could be. And you have to boil down and actually say, what is it about this that's really got you nervous? Because I can rule out a bunch of stuff, but if I don't get to the root of their fear, then they're going to be unsatisfied with the care. And that's where those famous words, "they didn't do nothing for me," come from. And so being able to dig down into that, and even, either picking it up, because sometimes they'll throw little cues in there about what the fear is, or they want to tell us, but or many times they're embarrassed to outright tell us, especially if they think it may be silly. But ask him, what's your big fear? What's got you nervous? You're clearly nervous about this. And so what's got you nervous? Oh, my 55-year-old father, mother, whatever, aunt, uncle, had chest pain and then had a heart attack. And okay, that's your fear. Let me explain to you why you're okay and what we're going to do down the road to make sure that you're monitored appropriately, that you have the right kind of follow-up care and things. And cancer is a huge one that people talk about because of obviously I think it's one of the big scourges of our generation is going to be cancer, and it touches so many people of so many ages. And many people are afraid, when they come in, they have a lymph node that's enlarged, and do I have cancer? No, you don't have cancer, but yeah, you do have a soft tissue infection here we need to deal with. And making sure that you explain those things and check them out and do everything that you can do to address the big fear, but also the information necessary for what the real issue is for which they presented. What are some final thoughts, some nuggets that you can send home with the listeners, the physicians out there, in terms of what you see and what they can do better when they get into their departments?
Well, I think the number one thing that I'd like people to take away is that enhancing your skill at communicating with patients and leading your team is great for the care of your patients and is great for your team, but it's also really, really good for you as the clinician. Your shift is going to be smoother. You're going to leave sooner afterwards. Things are going to, people are going to be smiling at you and happy when they see you coming in for work. So it really is worth putting some effort into to get good at these so-called soft skills of emergency medicine. Think of them like a procedure, like an airway procedure, or like a joint reduction. Sometimes the communication is the critical procedure that you're doing for the patient that is life-saving.
All right, so talking with Dr. Stefanie Simmons, and how can folks get information from you, either via email or on the social web?
They're welcome to visit my LinkedIn profile. My email is ssimmons@epmg.com, and if anyone's interested in developing their own coaching program or coaching their docs, they're welcome to contact me.
All right, thank you so much for your time, and I'm sitting, and I've got to wrap it up because I'm sitting here and I apparently have no control over my feet, and I just keep kicking your feet over and over and over with my big old Kentucky boots on. As for me, you can contact me, youreverydaymedicine@gmail.com, youreverydaymedicine@gmail.com, @everydaymed on Twitter, and also make sure that you're subscribing to the podcast either on SoundCloud or iTunes to make sure that you're getting our weekly releases. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.